Hello, you've reached the Healthcare Reform section of the FEAR Insurance Services website. We've entitled this short presentation, What You Need to Know About Healthcare Reform. This presentation was updated on October 3rd, 2013, so if anything new develops after that date, and we're sure that it will, we'll update this presentation with the most current information. So sit back and learn what you need to know about healthcare reform, presented by FEAR Insurance Services of Roseville, California. So, the official name of all of this is the Patient Protection and Affordable Care Act. Some people call it Obamacare, others call it the Affordable Care Act, but we call it the Act for short. It became law in March of 2010, and without question it is the largest piece of legislation related to health care in the United States history since the passage of Medicare and Medicaid in 1965. A number of provisions of the law have already gone into effect, including those items listed on the screen. As you probably know, the Supreme Court ruled that the Act is constitutional in June of 2012. Since then, and after the national elections in November of 2012, a number of regulations have been released which get into the details of how the Act will be enforced. Love it or hate it, Obamacare is now the law of the land, and we'll have to abide by its provisions going forward. Okay, so here's a quick overview of what's going to happen in the upcoming months as the law goes into effect. Beginning January 1st, 2014, the individual mandate begins. This is the provision that everyone is required to purchase essential health benefits or pay a tax. The federal Medicaid program for the poor is expanded in most of the states, including California. A health insurance premium subsidy becomes available for qualified individuals. All health insurance coverage becomes guaranteed issue, and health insurance policies can no longer exclude coverage for pre-existing conditions. Health insurance exchanges or marketplaces begin operation, and some new health insurance taxes and fees go into effect. On January 1st, 2015, the mandate for large employers to offer health insurance coverage to their full-time employees goes into effect. These same large employers will be allowed to join in the public health insurance exchanges in 2017, and in 2018 an additional tax, the Cadillac tax, goes into effect. Again, this is a very high-level overview of what's going to happen. Now we'll get into some of the specifics of these various provisions, starting with how this will affect each one of us personally. So let's first address what the individual mandate is. On January 1st, 2014, the law requires that all American citizens and legal residents will have to purchase an essential health benefit plan from an insurer or health plan. Failure to purchase that coverage will result in the person being assessed a special tax. The Act does allow for a number of exemptions from having to comply with this provision, including religious objectors, incarcerated individuals, individuals whose income falls below 100% of the federal poverty level, members of Indian tribes, people with no income tax liability, individuals who are not lawfully present, and those who are not covered for a period of less than 3 months during the year. So, if the law requires that we must all purchase an essential health benefit plan or insurance policy, then what exactly are essential health benefits? Quite simply, an essential health benefit plan covers the following 10 types of services: ambulatory patient services, emergency services, hospitalization services, mental, substance abuse and behavioral disorder treatment, maternity and newborn care, prescription drugs, rehabilitative services and devices, laboratory services, preventive and wellness services and chronic disease management, and pediatric services including oral and vision care. Now, an essential health benefit plan may include deductibles, copayments, and other cost-sharing provisions, but it does limit those cost-sharing amounts to an annual limit of no more than $6,350 per person. That's in-network, with a maximum of 2 times for a family. So going back to the individual mandate, what exactly are the penalties that we pay if we don't comply with the requirement to purchase an essential health benefit plan? Remember, the mandate applies to all persons, both employed and unemployed, who are not specifically exempted from the law. The good news is that a person can also be exempted from the law if their employer provides them with minimum essential coverage. But if their employer does not provide minimum essential coverage, then they are still responsible for obtaining essential health benefit coverage for themselves or their family, or they will pay the penalty. So what is the penalty? Well, in the first year, 2014, the penalty is the hire of either 1% of gross household income or a flat $95 per person. For example, a single person earning $16,000 a year who fails to purchase essential health coverage will be assessed a penalty of $160, which is 1% of $16,000. They pay that penalty at the end of the year when they file their personal income tax return. Now, if that same person had one dependent, for example, a child, and the same $16,000 earnings, their penalty for failure to purchase essential health coverage would be $190, which is $95 times 2 people in their family, which in this case is higher than the 1% penalty of $160. Make sense? You should note that these penalties increase in 2015 and again in 2016 to the amount shown on the slide. By 2016, that same individual will pay the higher of 2.5% of their gross household income, or $696 per person, if they fail to purchase essential health benefits in that year. Okay, so now I need to explain what this expansion of federal Medicaid is about. Medicaid is the federal government program that provides health care for the poor. Like Medicare, which is health care for senior citizens, Medicaid has been around since 1965 and is generally available to persons who live at or below the federal poverty level. The next slide is a chart of the federal poverty level for 2013, so we'll be able to put some of the numbers with these percentages together in just a minute. You should know that the Medicaid program is administered by the states, and each state has slightly different rules for how they run this health care program for the poor. In California, we call it Medi-Cal, and the current rule for Medi-Cal eligibility is that it's only available to families with a child or children. So for the most part, it's not available to individuals without a child or children in their household. So PPACA gives states more funding to expand their Medicaid eligibility to individuals without children who earn up to 133% of the federal poverty level. That's up from 100% of the federal poverty level under the current rules. California has decided to expand Medi-Cal a bit more by allowing individuals who earn up to 138% of federal poverty level to be eligible to participate in the program. And at the same time, the Medi-Cal program is being expanded into all 58 California counties into a managed care program similar to what private health insurance coverage now looks like. So on the surface, it would appear that there will be more providers who will accept Medi-Cal patients than in the past, and that's probably a good thing. So I told you a minute ago that we have this chart that puts all of this in some perspective. This chart is very important because the next thing that we're going to explain is a new program that we call the Federal Health Insurance Premium Subsidy. It actually has a more complicated name having to do with something the law calls refundable tax credits, but the term that we use to describe this is a premium subsidy. And that subsidy is available for qualified individuals and families. Please take a look at this chart very carefully and bear with me for a moment because this is really important. If you're a single person, a household of one, the 2013 definition of the federal poverty level is an annual income of $11,490. If that same person has a child, so they're now a household of two, the current definition of 100% of the federal poverty level income is $15,510 a year. You got it? So Medicaid is being expanded in 2014 here in California to include individuals who have annual income up to 138% of the federal poverty level. Under this new arrangement beginning January 1st, 2014, a single person can now earn up to $15,856 annually and may be qualified for Medi-Cal benefits. Now, please note that the figure showing what that same person's income is for them to be at 400% of the federal poverty level. That number is $45,960. Again, This is the annual income for a person considered to be at 400% of federal poverty level. This 400% amount is very important, as you will see in a minute. Before we leave this chart, just look at where a typical family of four will be: a husband, wife, and two kids. We've highlighted this in yellow. The current definition of 100% of the federal poverty level for them is $23,550, and that's going to go up to $32,499, making that family eligible for Medi-Cal coverage. Note also that their income at 400% of the federal poverty level is way up there at $94,200 a year. So remember that amount as we go to the next slide. So there are some important things you should know about this new federal health insurance premium subsidy, which becomes available to qualified individuals and families on January 1st, 2014. First, the subsidy is a sliding scale refundable tax credit, which means the higher a person's income, the smaller the subsidy amount. 100% of the subsidy is generally available to persons whose income is between 138 and 200% of the federal poverty level. So for that single person on the previous slide, those amounts are $15,856 and $22,980. At 200% of the federal poverty level income, a subsidy amount begins to shrink until you reach 400% of FPL. For that single person, that 400% level was $45,960 of annual income. Second, the subsidy you receive is paid directly to the health plan in which you enroll through a public or government-run exchange. Now, we'll talk more about that exchange in a minute. If you don't enroll for coverage, then you don't receive a premium subsidy. That's all there is to it. Third, the subsidy is not available to individuals or families who have, quote, affordable, unquote, coverage offered to them by their employer. Quite frankly, the government wants employers to make coverage available to their full-time employees and not enroll in an exchange. But if that employer does not offer coverage which meets the essential benefit standard that we explained earlier, or the coverage is considered unaffordable, then the employee may be eligible for a premium subsidy through the workplace. Now we'll talk more about what is considered affordable coverage through the workplace a little bit later. Fourth, the subsidy amount is tied to a specific level of benefits offered through the exchange. We'll talk more about these benefit levels in a minute, but basically there are now 4 benefit plan levels available: a platinum, gold, silver, and bronze. In this case, the subsidy that a person can receive is tied to the cost of the silver benefit plan where a person resides. Finally, one other important thing. Eligibility to receive a subsidy is based on providing documentation of a person's income. Now, this can get a bit complicated, but in a nutshell, if you can produce proof of what their prior year's family income was, for example, a tax return or paycheck stubs, then the exchange will be able to determine your eligibility for a premium subsidy. There are penalties for people who deliberately underestimate their family income in order to obtain a higher subsidy, so you need to be careful when you apply through the exchange. Obviously, we suggest that you work with a certified insurance agent for the exchange, such as Fear Insurance Services. Effective January 1st, 2014, there are some important changes being made to the health insurance market that you need to know about. First, as we said earlier, all health insurance coverage will now be guaranteed issue and guaranteed renewable. So you cannot be turned down for individual coverage because of a pre-existing health condition, and you cannot be dropped by your insurance plan if you incur a claim. You do have to enroll during an annual open enrollment period, which initially began on October 1st, 2013, and will go through March 31st, 2014. Future open enrollment periods will be in the months of October through December of each year. You cannot enroll outside of an open enrollment unless you have had a specific change of family status, such as a birth, death, marriage, divorce, adoption, etc., or change of employment. We also mentioned earlier that all health plans may no longer exclude coverage for pre-existing conditions, and additionally, insurers may no longer limit your benefits annually or during your lifetime. All plans must have unlimited lifetime benefits. And finally, benefit plans must provide for preventive care services, certain preventive care services, as not being subject to any sort of cost sharing, such as a deductible, coinsurance, or copayment. Now we want to explain in general terms what health plan benefit levels and types will be like after January 1st, 2014. For individuals and small employer groups, the benefit plans that they will offer will now become much more standardized, making it somewhat easier to compare some plans side by side. All plans must fall within an actuarial value range, meaning that they must pay a certain percentage of claims within that category. There will now be 4 benefit plan levels available: Platinum, which has a 90% actuarial value; Gold, which has an 80% actuarial value; Silver, which has at least a 70% actuarial value; and finally Bronze, which has at least a 60% actuarial value. So again, actuarial value means the average of how much a plan pays of the claims for a person after you factor in any deductibles, coinsurance, copayments, and the maximum out-of-pocket limit for that plan. Essential health benefit plans must have an actuarial value of at least 60%, the bronze level. There will still be basic types of health plans that you're familiar with. HMO plans, which feature the use of an exclusive provider network. You can only use a network provider. PPO plans, which feature the use of a preferred provider network and give you the ability to go in or outside of network. And finally, indemnity plans, which allows you to use any provider you want. There are no networks. Finally, you need to be aware of the fact that many of the individual and family plans will now be featuring the use of a narrow provider network, meaning that not necessarily all of a health plan's contracted providers may be accessible in this new narrow network program. For some health plans, the use of narrow provider networks has resulted in a reduction of their premium rates in the first year of healthcare reform. Okay, so we've talked about benefits, provider choices, and market requirements for individual and small employer groups. Let's discuss now the rates that are going to be imposed on these two market segments. First of all, individual and small employer group rates will now be based on a new community rating system imposed across the entire United States. The individual states do have some flexibility in how they determine these community rates within their jurisdiction. So let me describe what's going to happen in California on or after January 1st, 2014. Rates will now be based on each person's individual age rather than the traditional age bracket. In the past, we had rates for ages 20 to 29 and 30 to 39, etc. Now we will see rates for each year. So a 32-year-old person will have a slightly higher rate than a 31-year-old, etc. What you need to know is that all rates are now being compressed, meaning that rates for older persons, say over age 50, are actually coming down slightly, while the rates for those under age 40 will be coming up, and in some cases substantially. This is due to a rate compression requirement within the new law. Individuals and small employer groups may no longer be rated up for health conditions, and family rates will now be based on the sum total of the individual rates for the husband, spouse, and each child, up to a maximum of 3 children in the family. Finally, rates will be based on the geographic area in which a person lives. In California, the state is divided into 19 geographic rating regions. So that brings us to the topic of health insurance exchanges. As mentioned earlier, these entities are created by the government to administer the healthcare reform program at the local level. The new law requires that an exchange is set up in every state, and each exchange must serve 2 distinct market segments, individuals and small employer groups. If a state fails to set up an exchange, then the federal government must do it for them. California was the first state to move forward to set up its own exchange, and it became operational on October 1st, 2013, when the open enrollment period began. The exchange has several responsibilities, including negotiating rates, benefits, and services with the various carriers, educate the public about healthcare reform, determining eligibility for the federal health insurance premium subsidy and any tax credits that a small employer may qualify for after January 1st, 2014. The exchange also has to bill, collect, and remit premium for the various health plans and is required to transmit enrollment data to the federal government, which indicates who has purchased coverage so they meet the requirements of the individual mandate by the end of 2014. Coming back to Covered California, it has received nearly $1.5 billion in federal funding to become operational. It is contracted with 13 health plans throughout California for the individual exchange and with 6 health plans for the small employer or shop exchange. Here in the Sacramento area, the individual health plans are Anthem Blue Cross, Blue Shield of California, Kaiser Permanente, and Western Health Advantage. Fear Insurance Services has become a certified insurance agent for the exchange and is able to enroll our clients into any of the exchange programs for both individuals and small employer groups. So as we wind down this presentation, we want to explain some of the key parts of how employers are affected by the new law. As mentioned earlier, the original law contained a provision called the Employer Shared Responsibility Requirement. We sometimes refer to that as the play or pay mandate, meaning that an employer either provides health benefit coverage to their employees or they pay a fine or tax to the federal government. This provision was supposed to go into effect on January 1, 2014. However, on July 2, 2013, the administration announced that it was pushing back the enforcement of the employer mandate by 1 year to January 1, 2015. That's the good news. Now, in a nutshell, here is what the employer mandate is. It applies only to, quote, applicable large employers, unquote, who have 50 or more full-time or full-time equivalent employees. The mandate requirement has 2 parts. The large employer must offer coverage to all full-time employees, which are now defined as working an average of 30 or more hours a week or 130 hours a month. The coverage that is offered to these full-time employees by the large employer must be considered, quote, affordable and meet a, quote, minimum value standard in terms of the benefits it provides to these employees. If an employer fails to do this, they are penalized the lesser of $2,000 times the number of full-time employees less the first 30 employees, or $3,000 times the number of full-time employees who receive a premium subsidy from an exchange. Now, employers are not required to offer coverage to part-time or to seasonal employees, just to full-time employees. All employers are required to notify all of their employees of the existence of a health insurance exchange, and that notice was actually to have been delivered to all employees before October 1st, 2013. So remember, small employers, again, who have less than 50 employees, are exempted from this requirement of having to offer affordable coverage that meets the minimum standard value. We've mentioned several times in this presentation the term affordable coverage. This is an important provision of the law which you need to understand. If you are a large employer, 50 or more employees, then you must offer coverage to your employees which is considered affordable. Affordability has nothing to do with the price of the insurance you pay. It has to do with how much you charge the employees for their coverage. If you're a small employer, you're not required to offer any coverage, affordable or not. However, if an employee of an employer is offered affordable coverage through work, they will not be eligible for a premium subsidy through the public exchange. This is very important. So what is affordable coverage? The law defines affordable coverage which does not cost the employee more than 9.5% of their family income. But most employers have no idea what the employee's family income is. So the government said, here, you can base it on 9.5% of the employee's W-2 income from that employer, or the employee's hourly wage from that employer. So here's a real simple example. An employee is paid $10 an hour and has W-2 income at the end of the year totaling for 2,000 hours, it totals $20,000. 9.5% of $20,000 is $1,900. Divided by 12 months equals $158.33 a month. That's the maximum amount that employer can require the employee to pay for their coverage for as a single person. to be considered affordable. Or, put another way, that employee earns $10 an hour. 9.5% of $10 an hour is 95 cents an hour. That would be the maximum contribution that the employer would take out of an employee's paycheck for single coverage. That $1,900 per year is effectively the threshold for a $10 an hour employee. So there are just a few more things you should know about PPACA, so bear with me just a couple more minutes because we're almost done. In 2014, there will be 2 new taxes or fees imposed on health insurance plans. The first is a national health insurer tax on all fully insured plans, be they individual or group. The actual tax is to be added to your premium rate, and it will vary by carrier, but will range between 1.5% and 3.5% of premium. It's expected to cost about $500 per family per year, and it will generate about $8 billion in revenue that will provide funding for the premium subsidy that we talked about earlier. Additionally, there's a national reinsurance fee that will be charged to all fully insured and self-insured health plans. This fee is $63 per person per year, or $5.25 per person per month. Again, that's per person, not per employee. Both of these taxes will show up on your premium bill beginning January 1st, 2014. There are 2 other issues of which you should be aware. The maximum waiting period for any employer group plan will now be 90 days, not a day longer. California happened to pass a bill which imposes a maximum 60-day waiting period on all small employer groups who have fully insured coverage. That law is being debated now, but most carriers will tell you that you need to comply with this provision. So if you have a waiting period now greater than 90 days in your company, you need to adjust it back to 90 days, or if you're a small employer, to 60 days. There's a couple of other quick things. It's expected that there will be enforcement of a new non-discrimination requirement of PPACA, in which employers may be fined $100 a day per employee if they happen to offer a discriminatory health plan, meaning one class of employees get a better plan than another class. That enforcement of this requirement was put on temporary hold, but is expected to be enforced in either 2014 or 15 once the employer mandate kicks in. And we also mentioned earlier the Cadillac tax. This will come into play in 2018 when health insurers will be charged an excise tax on any plans that cost more than $10,200 a year for an employee or $27,500 a year per family. Obviously, such a tax will be passed along to the employer who is offering this coverage in the form of a rate increase. I know it sounds crazy, and believe me, we know this, but the provision is in the law, and unless Congress changes the provision and the President approves its removal, it's going to take effect. So we've come to the end of our little presentation. We hope it doesn't come across as an infomercial, but frankly, there's no easy way to tell you the story about how healthcare reform affects all of us, individuals, families, and businesses. The law itself is over 1,700 pages, and they've now issued regulations that exceed 20,000 pages. It is really incredible. For our clients or prospective clients, we encourage you to contact our office during business hours and make an appointment to come by and sit down with us, and we can explain more of the details of PPACA. There are many other finite issues that we can share with you. Of most importance is to help you strategically plan on how to deal with this. We subscribe to a very sophisticated compliance system that we can offer to our larger clients at no charge. We can help you map out a compliance strategy in dealing with the employer mandate. For our small business and individual clients, we can sit down with you, run the numbers on the potential costs and the premium subsidy impact for you personally. Our producers are all becoming certified as exchange agents, and we can get you answers to your questions in very short order. Thanks for taking the time to listen to this presentation on the Patient Protection and Affordable Care Act, what you should know about healthcare reform. If you need additional information, you can call us at 1-877-663-3273 or email us at insurance@fearcorp.com. Our office is located at 2140 Professional Drive, Suite 155 in Roseville, California, 95661. We're just 2 blocks from the Kaiser Hospital off of Douglas Boulevard. Take care and have a great day. Bye.